So yeah, we are live now. So yeah.
Okay. Okay. Good afternoon, everybody, and welcome to this session on advances in pediatric infectious diseases. My name is MIRJAM, KNOL, and I'm working as an epidemiologist at the National Public Health Institute in the Netherlands, in the department on vaccine preventable diseases. And we will have three speakers in this session. The first one is DIMITRI DIAVATOPOULOS, and he is an associate professor in infectious diseases at the Radboud University in the Netherlands. And he will be talking about recent developments in Pertussis. And then next, I will be presenting on pneumococcal surveillance data after PCV10, the pneumococcal conjugate vaccine in the Netherlands. And as a last speaker, we will have George Sirogianopoulos, and he is a professor in pediatrics at the University of Thessaly in Greece, and he will be talking about current trends in complicated pneumonia. So we will first have the three presentations, and then we will have questions taken at the end. So we will have time for discussion at the end of the three presentations. So please submit questions to all of us as speakers. So first, I will give the word to DIMITRI to start his presentation.
All right, thank you, Mirjam. I will share my screen now. Oh, can you see it? Can everyone see it? Yeah?
Yes.
All right. Okay.
Go ahead.
Well, good afternoon, everyone, and thanks to the organizers for inviting me to give a talk at the EIP. So I was asked to give a presentation about recent developments in pertussis, and I think it's pertussis is quite an unusual case in that we have a long history of vaccination. But we are using two different types of vaccines, and there are not that many infectious diseases where we are vaccinating against that have such distinct vaccine types, and it gives for some interesting questions, and I'll actually go through them. So pertussis, just to recap, is a highly contagious acute respiratory disease characterized by uncontrollable coughing. It's mostly caused by Bordetella pertussis, gram-negative bacterium, and as I mentioned, it's highly contagious. And as everyone is now familiar with the term R0, the R0 of Bordetella pertussis is actually quite high. So it's in the order of between 10 and 17, which makes it highly contagious. It's also vaccine preventable, and that's also we started vaccinating in the 1940s and 1950s. So these are the typical stages of pertussis in terms of disease. So basically following like infection and an incubation period, like you go through the catarrhal stage, and this is usually not the stage where we can already say that you have pertussis, because it's characterized by atypical cough and you get a bit of rhinorrhea. And then once you move into the paroxysmal stage, then we are starting to see the characteristic hallmarks of pertussis, such as lymphocytosis and the vomiting whoops, and also sometimes cyanosis. And then over a period of weeks to months, we enter the convalescent recovery stage, and then, but it takes a long time to recover from pertussis. In terms of the epidemiology, nowadays we don't see pertussis very often anymore. At least not as often as before vaccination was introduced. So this is data presented from the US, which dates back to the 1920s. And as you can see, the number of pertussis cases in the USA was actually quite high, until the first pertussis vaccine was introduced in the 1940s in the US. And this first vaccine was basically was based on the whole bacterium. It's also called the whole cell pertussis vaccine, which consists of the heat inactivated form of Bordetella pertussis. It was combined with diphtheria and tetanus, and together they are actually one of the pillar stones of modern day vaccination programs. And that was actually quite successful, and it led to a significant reduction in cases. But what we're now seeing actually is that the number of cases of pertussis is actually increasing again, and not just in the US, but also in the Netherlands. As I've mentioned, we don't have data going back to the 20s, but you can see here is that the number of notifications in the Netherlands is also going up. And if you compare this to other infectious diseases that are also targeted in our national immunization program, you can see is that like pertussis is by far the least controlled vaccine preventable disease in our immunization program. And this is also not like so in the 80s and in the 90s, a new vaccine was developed for pertussis. That was because there was a lot of reactogenicity because of the wholesale pertussis components, and people were concerned about safety. And so these new vaccines are basically consisting of protein components, antigens of the pertussis bacterium, which are also combined in a DTaP vaccine. And as you can see here, it has not really prevented the re-emergence of pertussis. So these following the initial reports is that the acellular pertussis vaccines were not probably not as good as we wanted them to be. There were a couple of important studies done, and one of these studies is a story from Australia, where they followed a birth cohort of children around the time is that the switch took place from a wholesale to the acellular pertussis vaccines. And these children were followed over time, and actually up to 10 years after they were vaccinated with either a wholesale vaccine or an acellular pertussis vaccine, the pertussis notifications in these age groups were actually monitored. And what you can see here is quite interesting, is that when your first dose in the primary vaccination series is an acellular pertussis vaccine, is you're more prone to develop a pertussis. Whereas if your first dose is a wholesale vaccine, even if your second or your third dose is an acellular pertussis vaccine, then you still have a reduced chance of developing pertussis. So that was the first indication, is that primary vaccination actually makes a difference. Now, the problem with pertussis has been is that there are not like the animal models that we had available, which were mostly mouse models, is that they didn't really recapitulate the disease aspects that we see in humans very well. And that changed like in 2014 when the first report came out about a baboon challenge model for Bordetella pertussis. And in this model, the baboons that are challenged also juvenile or neonatal baboons, and actually they develop disease. And both leukocytosis, as you can see here the white blood cell counts, and naive animals actually develop quite a high leukocytosis like following challenge. Interestingly, we can see here is that both the acellular pertussis vaccine as well as the wholesale vaccine are actually very well capable of preventing disease. Now, that changes like when we actually look at prevention of infection. What you can see here is the number of bacteria like in the respiratory tract that we find back after challenge. And what you can see here is in blue, you can see the naive animals like that were challenged with a Bordetella pertussis, and you can see is that like over time is they're starting to clear the infection, and by about 1 month, a little bit over 1 month, is they have cleared the infection. Now, animals that were vaccinated with a wholesale vaccine actually were able to rapidly reduce the infection and clear it from the respiratory tract. Now, the acellular pertussis vaccine is quite different here, because initially it is able to contain the infection, but what is striking is that actually it takes longer even to clear the infection than the naive animals. And this has been shown now, not just in baboons, but even in mice, and it's actually a reproducible effect. So this suggests is that like the acellular pertussis vaccine actually really polarizes your immune response to an immune response that is still protective against disease, but not so protective against clearance of infection. Now, and when these animals were tested for their ability for the T-cell responses, there were quite some significant differences found between the acellular and the whole cell pertussis vaccine, and that like those differences are mainly there in the Th17 component, which is strongly induced by the whole cell vaccine, but also the Th2 response, which is mostly induced by the acellular pertussis vaccine. So there is this sort of T-cell polarization, this skewing towards the Th2 type response that we're seeing with the acellular pertussis vaccines. Okay, and what is interesting here, and you don't need to really look too much in all of these figures, but like this is a study that was done in the US in individuals that were either primed with an acellular pertussis vaccine or a whole cell vaccine, and that were then received an acellular pertussis vaccine, a booster vaccine at the moment of the study. And what you can see here is that the responsiveness to this booster vaccine is actually much better in people that were primed with a whole cell pertussis vaccine as compared to individuals that were primed with an acellular pertussis vaccine. And the same differences were also found in terms of the Th1 response, the Th2 response, and the Th17 response, which confirms the findings in the baboon studies, but now in humans. This is a study from the RIVM, where also a cohort was followed over time, and like again, with the two birth cohorts, like primed with a whole cell vaccine or with an acellular pertussis vaccines. And in this case, they didn't look just at the cellular response, but also at the distribution of the different IgG subtypes. And what you can see here, which is quite striking, is that individuals that were primed with an acellular pertussis vaccine, now when they receive a booster dose with a acellular pertussis vaccine, is that a significant proportion of the antibodies that they develop in response to this intervention is actually made up of an IgG4 type. And there are 4 types of IgG. And what is interesting is that this IgG4 type is actually quite well capable of neutralizing and has a high avidity of binding to its targets. But at the same time, it is losing its abilities to bind complement. And this is important because this complement activity is actually important for inducing the killing of bacteria. So you get a lot of antibodies that are opsonizing the bacterium, but these antibodies are not able to induce killing of this bacterium. And that's of concern, obviously. Now, this is a study that was done in the US where they looked at vaccine effectiveness. And US is one of the first countries in the world where they switched from a whole cell to an acellular pertussis vaccines. And here they followed the vaccine effectiveness following a 6th dose of an acellular pertussis vaccine. So during infancy, they receive a vaccination doses, and then they receive a preschool booster dose, and then during adolescency, they also receive a Tdap vaccine. And what is really striking here is that 4 years after they have received their Tdap vaccine, is that the vaccine effectiveness has waned from 70% to 10%. And so this is something that especially occurs in individuals that have been exclusively vaccinated with an acellular pertussis vaccine. So this is something of concern that we are looking into as we speak. So there have been suggestions that the notifications that we see in the population, they're basically they're based on a clinical features, but that we are basically underestimating the number of asymptomatic or subclinical infections that are taking place. And that is certainly true. There are many cases that are pointing to this. I'm just pointing out here, this is a study that was done also again by the RIVM. This is a cross-sectional study in the Netherlands called the Pinter study, where different ages and different geographical locations in the Netherlands, up to 8,000 people are sampled, and blood is collected. And then in this case, we're screened for antibodies against pertussis toxin. And this is one of the components in the acellular pertussis vaccine, also in the whole cell vaccine, by the way. We know that the antibodies against pertussis toxin actually wane quite rapidly after vaccination. So if you have high titers of antibodies against this pertussis toxin, it suggests that you have recently been exposed to Bordetella pertussis. So in 1995 and 1996, when this study was done, about 4% of the individuals above the age of 9 were like had high titers, like suggesting recent infection. But now when we move to 2006 and 2007, so this is following the switch from the whole cell to the acellular pertussis vaccine, we see now is that 9% of the Dutch population over the age of 9 has signs of recent exposure, suggesting there is quite a lot of subclinical spread of Bordetella pertussis among the population. Like in addition to that, like something else that we have been seeing in the past couple of years is the emergence of bacterial strains that do not produce one or more of the components that are in the vaccine. In this case, protectin is one of the key antigens where we are seeing that a lot of the strains that are being isolated are now losing expression of this antigen, and this is a publication where they have plotted the proportion of all the Bordetella pertussis isolates that have been collected and tested for the expression of protectin. So, and then what you can see here is that there is actually an association between the time that the acellular pertussis vaccine was implemented. In this case, we're talking about protectin-containing acellular pertussis vaccines. And if you're very close to the recent implementation, that you don't see a lot of protectin deficient strains, but the further you are, like the longer it has been since you have introduced this vaccine, then what we're seeing is that like the chances of having protectin deficient isolates actually increases, suggesting there is enormous selective pressure happening on these strains to lose expression of protectin. We are also seeing that these strains are actually not very attenuated, and they're still able to cause disease, which is obviously, if they wouldn't, then it would not be a problem. But that's not the case, unfortunately. So just to summarize this bit, what I want to show you here is that we have observed a resurgence of pertussis. But interestingly, it has been primarily the case in countries that are using the acellular pertussis vaccine. So we're also seeing an increase of pertussis disease in fully vaccinated individuals. There's quite some evidence that there is increased asymptomatic or subclinical transmission of Bordetella pertussis, which coincides also with the emergence of vaccine antigen deficient strains. What is also quite clear is that up to now, we are not seeing very strong evidence of resurgence in countries that are still using the whole cell vaccine, because the acellular pertussis vaccines are almost exclusively used in high income countries, whereas most low and middle income countries are still using the whole cell vaccines. So we have now, we're now at the situation where we are using the acellular pertussis vaccines, and the problem is that these vaccines were licensed on clinical efficacy. At least the first generation of the DTaP vaccines were licensed on clinical efficacy. Now, the subsequent iterations of the DTaP vaccines, including the hexavalent vaccines that are used in many countries today, these were not licensed based on clinical efficacy, but based on non-inferior immunogenicity. Now, the problem is that it has been made clear by the FDA and by the EMA is that like the next generation of pertussis vaccines should actually have superior efficacy. Now, the big question that we have is how do we cross this bridge? And that's a question that we have been discussing in this community for quite some time now. And there are a couple of barriers to licensing these vaccines. One of the key issues is that like nowadays, like we have a universal recommendation for pertussis vaccines. And we are seeing like that many of the countries that are using DTaP vaccines have over 90% vaccine coverage. So this was a situation in the 1980s where you can see the vaccine coverage, and you can see that there are very large regions in the world where the vaccine coverage of DTP, 3 doses in infants was actually quite low. So this was a time when these large efficacy trials were conducted in Europe and in Africa. Now, when we move forward to 1990, to 2000 and to 2010, and up to where we are now, you can see is that these trials will be much more difficult to perform because the vaccine coverage is so high. At the same time, we're also seeing is that the problems that we are encountering with these acellular pertussis vaccines are not there in the short term. Most of these vaccines are actually quite efficacious in the short term. We see a low pertussis incidence early after primary vaccination. So this is a study in the US from the Kaiser Permanente hospital area, where they followed the vaccine effectiveness, where they studied the vaccine effectiveness after 4 doses or after 5 doses. And you can see is it's starting to increase here 3 years after vaccination. Now, if you want to design a phase 3 efficacy study where you have to wait for 3 years and the incidence is actually quite low, of clinical disease, then you're in trouble, because like we have to vaccinate very large number of people to actually see a significant effect on clinical efficacy. And at the same time, these effects do not occur until several years after vaccination. Another issue with licensing these vaccines is that like pertussis outbreaks do not happen all the time in one region. Like what we are seeing is that there are epidemic cycles, but these can be quite regional and occur every 3 to 5 years. And it's not always like easy to predict like how and when these epidemics actually will occur, which will also make it difficult actually is to organize a clinical study, because what you want there, you want to have a high disease incidence, like if you want to show your positive effect of your vaccine. So we have now reached a situation where large-scale efficacy trials are currently not feasible. At the same time, we run into the issue is that formal correlates, immunological correlates of protection have not been identified or are not recognized for Bordetella pertussis. So we recognize this issue, and that's why we initiated this, like the Periscope project. So the Periscope project is a public-private partnership funded by the IMI and the Bill and Melinda Gates Foundation, where we are actually looking at correlates of protection. So it's made up of 22 partners, of which 20 are public partners, and it's and we have 2 partners from the vaccine industry. And the objectives of our consortium are to actually foster expertise and increase capacity in Europe to evaluate new pertussis vaccines in clinical, but also in preclinical models. And at the same time, also identify potential biomarkers of long-lasting protective immunity to pertussis. So we started in March 2016. Duration is 16 months. We're extending it for 1.5 years. So, but I want to take you through the things that we are doing at the moment, and to give you an idea of how this can help license new vaccines. So the issue, as I mentioned, is that like there's not a single study design that will give you all the answers like that will help license a new vaccine. So what we're doing here is like we've set up a series of studies, and some of these are preclinical studies. For example, the baboon model will give us insight into disease and colonization endpoints. The problem with this model is that you cannot like include like hundreds of animals in these studies, and there will still be a translation gap from going from animals to humans. But it will give you qualitative information about disease and colonization endpoints. Now, to bridge that with humans, like what we have done is we have been working on a controlled human infection model, and this controlled human infection model I will go into a little bit. So some of the considerations that we took when we went through this exercise is that, well, obviously pertussis, there's a natural history of pertussis happening in the population. But some of the other issues, obviously, is things you have to consider is like, well, if it is very transmittable, then how do we deal with that, right? Because like that's something you have to take into account. Like once you actually deliberately expose volunteers to a bordetella pertussis infection, the question that we had is like, does asymptomatic colonization also really exist or not, right? Because once we induce an infection in a volunteer, and that volunteer actually moves on to develop clinical disease, the problem with pertussis is that like the antibiotics will help preventing transmission, but once you actually enter the clinical stage, it will be very difficult to actually inhibit the disease aspects. Obviously, like pertussis vaccines have been around for quite a long time. So we are not dealing with individuals that are completely immunologically naive, but they have pre-existing immunity. There was also a historical example of a human challenge with bordetella pertussis, which was done in the 30s and was actually done in children, and it resulted in a very rapid onset of severe disease. And then obviously we have to take into account like the escape medication, like what if we give azithromycin, does it lead to clearance of carriage? So the colonization model that we had in mind actually targeted the first days of infection, so the first two stages before we move into the paroxysmal stage. So in phase A, the objective of our study was to find the inoculum dose that caused safe colonization of more than 70% of exposed volunteers. Volunteers were recruited, were given an intranasal inoculation volume of 1 ml, which prevents, basically what we wanted to restrict the infection to the upper respiratory tract and not let it go to the lower respiratory tract. We also didn't want people that had been through a recent vaccination or infection, because then it will be very difficult to induce colonization in those individuals. And our primary endpoint was to induce colonization without disease. So this was the overview of the study visits. So volunteers were screened and then visited the hospital. And I forgot to mention that, but this study was performed by at the University Hospital in Southampton, and following inoculation at day 0, they had to remain in the ward for 16 days. And after 14 days, antibiotics were given to eradicate the infection, and then they were monitored for 2 more days, and then they were sent home, and they are still being followed up as we speak. I'm just gonna skip this slide for now. I think this is showing the timeline of the dose escalation study that we did. So we started with only 1,000 bacteria, because we were thinking is that well, most of them will become infected, but in fact, none of them were colonized. So per protocol, we moved tenfold up and we re-challenged them, and 3 out of 4 were colonized. And we were thinking, well, that's actually quite good. So we repeated the study with 5 more volunteers with the same challenge dose, but then only 2 were colonized. So we now had 5 out of 9 that were colonized. So that was not above 70%. So per protocol, we increased again, went to 50,000 CFUs, only 2 were colonized. Then we went to 100,000 CFUs, 4 were colonized. We repeated that, 4 were colonized out of 5, repeated it once more, and again, 4 were colonized. And that resulted in the conclusion of phase A, where we actually identified the standard inoculum dose and set it at 10 to the 5 CFU, which then induces about 80% colonization. So that colonization fraction is depicted here. What you can see here is that at the 10 to the 5 CFUs, we reach like about 80% colonization. Now this slide shows the colonization dynamics over time, and like based on culture, but also based on PCR. And what you can see here is that so over some of the volunteers are starting to clear it by day 14, but some also don't, and actually quite high. Some have lower CFU numbers, and this is something that we are still looking at the moment. What is important to mention is that we didn't really observe any real significant clinical symptoms like that were persisting for more than 4 hours. They were actually quite rare. Maybe a little bit in some of the volunteers. We're starting to see some nasal congestion and rhinorrhea in the 10 to the 5 CFU cohort. But that was actually quite mild, and over 7,000 cultures were taken in this in phase A of the study, and like from different surface areas, like where these people where these volunteers were sitting, from masks even, and none of them returned positive. So in phase B, we are now actually moving to an outpatient setting, and this study is ongoing as we speak. So just some basic immunology. We measured antibody responses following inoculation, and these are showing the fold changes in pertussis toxin and protectin and several of the antigens. We can see here is that what's very interesting here is that individuals that are not colonized typically don't show an increase in antibody response, whereas people that do get colonized do show an increase in antibody responses. Right. So that brings me to the final part of the talk, and that's the vaccination studies. And so we're doing trials in infants and also in pregnant women. We've also done a booster vaccination study in different age groups. The purpose of these studies is to develop new assays where we can potentially correlate it with the outcomes in the challenge models, as well as in patient studies, to identify potential correlates of protection. So as I mentioned, like the initial vaccines were licensed based on antibody titers. These are binding antibodies, ELISA titers, and nowadays we use multiplex assays. But as you can imagine, is that like not all of those antibodies contribute equally to protection. So some of these antibodies are like able to neutralize toxin, which is very important for prevention of disease. But some of them are also bactericidal or able to block adherence to the respiratory epithelial, or like induce opsonal phagocytosis by phagocytosing cells. And what we expect is that like only a fraction of the binding antibodies are actually able to predict in vivo protection. So this is part of ongoing work. For example, this is a serum bactericidal assay that has now been standardized and set up for Bordetella pertussis. This is working quite nicely, and one of the things that, for example, that were observed is that like out of all the antigens, actually antibodies against protectin are the only ones that induce bactericidal antibodies, which might actually be driving the emergence of these protectin deficient strains. Now, this is basically the final slide of the presentation. So what is important to mention here, so we are doing a lot of different clinical studies, also preclinical studies, where we're looking at different aspects, for example, in vaccination, in challenge studies, but also in convalescent patients, where on the one hand, we're looking at antigen-specific like quantities of antibodies, but we're also looking at different functionalities of these antibodies, where we are actually targeting the whole bacterium. At the same time, we have set up and standardized different cellular assays based on B cells, T cells, but even looking at innate immune responses. And together, we're integrating all of that in a systems immunology analysis, where we are hoping that like this analysis will allow us to identify markers that will be able to predict protection against infection on the one hand and disease on the other hand. So that leads me to conclude with this pie, where all of these different clinical studies are going to be very, very important for like moving along in the registration of these new pertussis vaccines. So that concludes the my talk. And so Miriam, I think I'll stop sharing now and we'll take questions at the end, I understand.
Okay, thank you very much, Dimitri, for a really comprehensive presentation. And indeed, we will take questions at the end. So please hold your questions for Dimitri. So I will now start sharing my screen to present my talk. Okay, so I will be talking about pneumococcal surveillance data and about pneumococcal conjugate vaccination in the Netherlands. So the objectives of this talk is to describe the epidemiology of pneumococcal infections after using the 10-valent pneumococcal conjugate vaccine, also to describe the role of infant vaccinations for elderly. And I will also talk about the influence of the SARS-CoV-2 pandemic on pneumococcal infections at the moment. So just as a starting slide about pneumococcal disease. So this is caused by a gram-positive bacterium, Streptococcus pneumoniae. And this bacterium has a polysaccharide capsule, which is the main virulence factor. And there are more than 90 serotypes known of pneumococci, which in various degrees cause disease. And the pneumococcus is a commensal of the upper respiratory tract, usually not causing any disease. And carriage prevalence differ for different age groups, and they can be around 60 to 90% in children, depending on also on the method used to detect carriage, and is lower in elderly, around 5 to 10%, also depending on which method is used to detect carriage. So in certain circumstances, the pneumococcus can cause disease. And then we discern two types of disease: invasive disease, where the pneumococcus is isolated from blood or CSF and causing meningitis, septicemia, or pneumonia. And we call it invasive pneumonia if also the bacterium is found in blood. As opposed to non-invasive disease manifesting as pneumonia, but also otitis media, which is highly prevalent especially in children. So in this pyramid, you also see the different disease entities with the highest incidence for pneumonia, otitis, but the more severity for meningitis and sepsis. So I will be focusing on IPD in this presentation, and we see for IPD especially a high incidence in young children, but also in elderly. And this is a graph showing IPD incidence by age group. This is data from the Netherlands, and this is actually data from 2004 to 2006, so before pneumococcal vaccination was introduced in infants. And what you see is that the incidence is really high in the young children, especially the under 1-year-old children, and also still in the 1-year-old children, and then decreasing in older children. And then the incidence is increasing again around the age of 50, 55, with kind of a linear increase across higher age groups. With increasing age. So there are different pneumococcal vaccines available. There are polysaccharide vaccines, which have been available for many years. They are actually not immunogenic in young children, and there's no immunological memory induced after giving these vaccines. There's also no booster response present. And also these vaccines have a rather short duration of protection. And the 23-valent polysaccharide vaccine is currently available, so including 23 different serotypes. On the other hand, we have conjugate vaccines. So these have been available since around 2000. And there, the polysaccharide is conjugated to a carrier protein, and therefore it does induce immunogenicity in children, or antibodies in children, and it also induces a memory response and a booster response, and it gives longer duration of protection. And there are different conjugate vaccines, including different serotypes. So the first conjugate vaccine was including 7 serotypes. And this vaccine is no longer available, but has been replaced by a 10-valent and a 13-valent vaccine. And also new vaccines are under development, including a 15 and a 20-valent vaccine. And hopefully they will be registered quite soon from now on. So looking at these different vaccines, so all these vaccines include the same 7 serotypes, and these were chosen based on giving a high incidence in disease, mainly I think it was mainly based on the incidence in the US, so not reflecting incidence in all countries worldwide. And then the 10 and the 13-valent vaccines added additional serotypes on top of these 7. And especially 19A is of interest, serotype 19A, as it is still rather, it is a serotype causing quite a lot of disease, and which was also increasing after the start of 7-valent vaccines. And it's also a big, one of the main differences between the 10 and the 13-valent vaccine. So if we look at pneumococcal vaccination in Europe, this is a scheme from the ECDC, from Vaccine Scheduler. And what you can basically see is that a lot of or almost all countries have introduced pneumococcal vaccination for children in their immunization program. Usually that's in a 2+1 schedule with 2 primary doses, either starting at 2 or at 3 months of age, and then a booster dose around 1 year of age. And well, you cannot really see it from this picture, but some countries use the 10-valent vaccine, some countries use the 13-valent vaccine. actually most European countries use the 13-valent vaccine. So what about vaccination in the Netherlands? So we started with the 7-valent vaccine in 2006 in a 3+1 schedule, and then changed to the 10-valent vaccine in 2011. And 1 year later, we also reduced the dosing, so to a 2+1 schedule rather than a 3+1 schedule. And only in 2020, we also started to vaccinate elderly with the 23-valent polysaccharide vaccine. A lot of countries already had recommendations for elderly, or have recommendations for elderly, but we only started in 2020. So vaccination coverage of the conjugate vaccine in infants has been really high in the Netherlands since introduction, around 95%. So already, well, after introducing the 7-valent vaccine, I think this is one of the first studies showing what the effects were of that. So this is data from the US. They implemented PCV7 in 2000 in children. And what they saw is that not only the incidence decreased in the young children who were targeted by vaccination, but also in other age groups, in elderly and other age groups, the incidence decreased because of herd effect. So what this conjugate vaccine does is also reducing carriage in children, and thereby reducing transmission also to other age groups, and thereby also reducing the incidence of disease in other age groups. And this is, of course, this was good news, I think, for the countries who were implementing this vaccine later on, because, well, the cost effectiveness ratio improved because of this herd effect seen in other age groups, obviously. So that helped also the implementation of these vaccines in other countries. So in the Netherlands, we have a good IPD surveillance system existing of sentinel laboratory surveillance from 2004, covering 25% of the Netherlands. And labs send in positive isolates from blood and CSF, and we have data on age, sex, and date, and especially importantly also serotype. And we have also nationwide laboratory surveillance for children under 5 years old from 2008. And in addition to that, IPD is a notifiable disease for children who are eligible for vaccination. And from those notification data, we can obtain vaccination status and also clinical presentation and outcome. So, well, if we look at the effects of the PCV10 vaccination program, we can look at both impact and effectiveness. Impact is really on a population level, what the impact of the program itself was. So usually that's done using a kind of before-after analysis, looking before and after implementation of vaccination. And then we can look at age group, but also by serotype, looking at both vaccine serotypes and non-vaccine types. And by doing this, looking at impact, we look at both direct and indirect effects of the program. And this is also depending on the vaccination coverage and effectiveness of the vaccine. So that is included in this whole package of impact. We can also look really at the effectiveness of the vaccine itself. And then we can do that within vaccine eligible children. And what is often used for effectiveness of pneumococcal vaccination is that the IPD cases that are caused by vaccine serotypes are compared with IPD cases caused by non-vaccine serotypes. And then we can compare the vaccination in those two groups of children. So it's a kind of case control design, or a kind of test negative design, which is often used in influenza vaccination. So then we really estimate the direct effect of vaccination and showing effectiveness of the vaccine in the real world. So first, looking at impact, this is a picture showing the incidence over time of IPD in the Netherlands, and showing the moments of implementation of the 7-valent vaccine and the 10-valent vaccine. The different lines depict the different age groups. So the children, 5 to 49-year-olds, 50 to 64-year-olds, and the elderly. I hope the lines or the colors are visible, but let's first look at the under 5-year-olds, which is this line. And what is really clear from this is that after introduction of the 7-valent vaccine, the incidence really decreased quickly over time. And also after PCV10 introduction, the decrease continued. But the latest years you see that it doesn't decrease anymore. It's quite stabilized, or even maybe increasing a little bit again. If we look at the elderly, we see a little bit different picture, where we saw a decrease at the start or after implementation of PCV7, but from then on it stayed quite stable, and there was no clear effect anymore of the 10-valent vaccine. And in the other two age group, the incidence stayed quite stable actually over time, with no major changes in incidence. If we then zoom in into the young children, the children under 5-year-olds, under 5 year, this graph again depicts the incidence of IPD, but then stratified by the different serotypes included in the different vaccines. And here you see the overall incidence again, as in the previous graph. But now if we look at the different serotypes, we clearly see that the PCV7 serotypes, so the serotypes included in the 7-valent vaccine, the incidence of disease by these serotypes really decreased enormously, with almost no disease anymore in these latest years. And also for the PCV10 serotypes, we see really a reduction in disease, with almost no disease anymore caused by these serotypes. But at the same time, we do see that disease due to other serotypes not included in the vaccine is slightly increasing over time. So that also explains why we don't see a further decrease in the overall IPD incidence, as kind of the maximum vaccine effect has been reached, because all the vaccine serotypes have been eradicated more or less. But what we are left with is the non-vaccine serotypes. Well, here the same picture, but then for the elderly. Again, you see that the disease due to the the vaccine serotypes really decreased over time, with hardly any cases anymore at the moment. And also for the PCV10 types, you see this decrease. But at the same time, you do see the increase in the serotypes not included in the vaccine. So that explains that we don't see any reduction anymore in the overall IPD incidence. And in the other age groups, we see more or less the same. So a reduction in the vaccine serotypes, but an increase in the non-vaccine serotypes. So if we look at vaccine effectiveness, so that's really in the vaccine eligible children. Here you see number of cases that were caused by the 10 serotypes. So there were 13 cases since introduction of PCV10 who were eligible for vaccination, and of those 8 were vaccinated. So 62% of the PCV10 cases were actually vaccinated. If we compare that with the cases, the IPD cases, which were caused by non-PCV10 serotypes, we see that around 94% of those were vaccinated. Well, that's what you expect because that's the vaccination coverage in the population, or that's reflects this vaccination coverage. And if we calculate the VE, we come to 91%. So that's a really good vaccine effectiveness against the vaccine serotypes. So just a summary of this first part of the presentation. So we see a good effectiveness of PCV10. We do see a reduction in IPD in children and in elderly after introduction of at least a 7-valent vaccine, and also some further reduction in the children after the PCV10 was introduced. So the IPD caused by the serotypes included in the vaccine has nearly disappeared, and also in carriage, but at the same time, the serotypes not included in the vaccine have increased, and that's also seen in carriage. So the overall carriage rate has not changed that much, but the serotype distribution really changed, and also causing the overall IPD incidence not to decrease as much as we would like to, maybe because of this replacement. So the question is, what will these higher valent vaccines bring us if we would introduce them in children? Then you would expect, I think, again, a decrease because of the serotypes, but maybe because of ongoing replacement, this is also, this won't work in the long term, maybe. What we should see. Well, then there is the question about, well, should we use the 10-valent or the 13-valent vaccine? This is a graph from a large network of countries contributing IPD data, and from Europe, and there were several sites using PCV13 and several sites using PCV10, and this is data shown for elderly, and what you see is that for all type IPD, it doesn't really make a big difference whether you use the 13-valent vaccine or the 10-valent vaccine. So first, there was a significant reduction, but later on in 2015, and that also continues in later years, you don't see a significant effect anymore on overall IPD. So what about this PCV15 and 20, these new vaccines on the horizon? So in principle, they could prevent a lot of disease. This is showing the coverage of these vaccines currently in different age groups. And if you look at the elderly population, up to 75% of IPD is currently caused by the serotypes included in the 20-valent vaccine. This is data from the Netherlands. If you look at countries using PCV13, this green part is much lower, but overall they also, the distribution is quite similar with, or the coverage of this 20-valent vaccine is quite similar across countries, at least European countries. Okay, now moving on to the impact of the COVID-19 pandemic on IPD. Well, this is a picture showing the monthly number of IPD cases in the Netherlands, also by age group, for 2019 and for 2020. So this is the usual trend. The line depicts the 5-year moving average, and you see clearly the seasonal pattern with less cases in the summer. And then in March 2020, the pandemic hit us, and all kind of response measures were taken. And yeah, then the IPD rate really dropped tremendously. So in the second quarter of 2020, we saw an 80% reduction, and this was a little bit less, around 40% reduction in the third quarter, when also measures were relieved a little bit in the Netherlands after the first wave. But currently we are in the second wave, and then again you see that the number of IPD cases is very much reduced. And this is not, we don't see this only in the Netherlands, but a lot of countries have seen this. This is data from a recent publication on medRxiv, which collected data from many reference laboratories in the world. And they looked at different pathogens, so pneumococci, but also H. influenzae and meningococci. And they saw really a consistent pattern across countries with quite a reduction in disease due to these pathogens. As a control pathogen, they looked at Streptococcus agalactiae, and there was no difference noted in 2020. And this is not a respiratory pathogen. So yeah, it does indicate that really the social distancing measures reducing transmission, respiratory transmission, causes this reduction in IPD and also other respiratory pathogens. So regarding this impact of the COVID-19 pandemic, so currently we do see this reduction in IPD, probably or most likely due to less transmission, due to all the measures like social distancing, and also the school closures may have impacted this. But also less healthcare seeking behavior, less diagnostics, and less reporting could have played a role. Although I think this is less likely for these really severe diseases. But yeah, what to expect in the long term, because you could also imagine that COVID-19 is a risk factor actually for IPD in terms of being a bacterial superinfection. And at least in the Netherlands, we know that in the first wave of the COVID pandemic, a lot of antibiotics were used in these patients. And in the second wave, this was much more restricted. So so far there are not really indications of this superinfections, but maybe we've just not seen them because of antibiotic use. And you could also imagine that there may be increased susceptibility for IPD in COVID patients or former COVID patients due to lung damage. Well, we should also look at whether we see a rebound effect. So there was now really less IPD, but do we expect to see a kind of a rebound? And also we could have effects of decreased vaccination coverage against IPD. So I think in the Netherlands at this moment we don't really see a much decrease in vaccination coverage in infants, but this may be different in other countries across the world. So that could also in long term have influence on IPD incidence. So in conclusion, or as a take-home message for the first part of the presentation, we do see a large reduction on IPD in children and elderly because of introduction of pneumococcal vaccination. But by now, it seems that the maximum vaccine effects have been reached and the overall impact is reduced by the ongoing serotype replacement, and higher valent PCVs may be the solution for this. And currently we see a reduced IPD incidence due to the COVID-19 measures, but ongoing surveillance is really essential to monitor the long-term trends of the effects of the COVID-19 pandemic on IPD. Thanks for your attention. I will stop here and then okay. Stop share my screen, yes. And then we go over to the last presentation in this session, go ahead. Yeah, you see the present.
Is it okay, the presentation? It's
yes.
Okay.
Go ahead.
I'm going to present data on complicated pneumonia, and actually I'm going to refer to the incidence and the agents during the last decades. Well, pneumonia for pediatricians is an everyday problem, and actually not only for the pediatricians, but as we are in a meeting for pediatrics, we have to underline this age group. Regarding complicated pneumonia, there are several issues that we have to address. It's of course multilobar disease. It's when you have parapneumonic effusions, empyema, necrotizing pneumonia, when you have abscesses or cavities, and pneumothorax or bronchopleural fistula. Finally, can be pneumonia, that it's a complication of bacteremic disease that includes other sites of infection. Regarding pathophysiology, for the four most common entities, for parapneumonic effusion, we have a transgudative pleural effusion, and with empyema, it's purulent fluid in the pleural space. And then necrotizing pneumonia, we have lucencies or pneumatocysts on a chest X-ray, or cavities when we perform SCT image. Lung abscess, necrosis of lung parenchyma, producing one or occasionally several large, thick-walled cavities. And we have some X-rays presenting cases of complicated pneumonia. The most common cases are when we have pleural effusion and epidema. Actually, they represent different stages of the same pathophysiological process with inflammation that causes fluid to accumulate in the pleural cavity. We have 3 stages of progression. Reviewing the literature, we can see that there is a great heterogeneity in the criteria applied by the authors when they refer to parapneumonic effusion and when they use the term of empyema. And looking different papers, you can see in this table that some use the X-ray with the presence of a pleural effusion. And then when there is a purulent pleural fluid, it's another aspect that they use for empyema. And we see a positive gram stain that consider that it is an index for applying the term of empyema. Or if it is a positive culture of the pleural fluid, and actually here you see that all the papers, they agree with the positive culture. And following that, you see results of the cytochemistry of the pleural fluid evaluation. And actually, pH is considered to be a strong one that you index that you can use in order to classify as empyema. Some use 7.2 or less, or 7.1 and less. However, you can see that there are papers that they don't present so clear, in a clear way, the criteria that they applied for the definition of empyema. What about epidemiology? It's clear-cut that complicated pneumonia prefers infants and young children. And from different countries, we can see from Israel and Taiwan actually quite the same picture of the age groups where you can see the empyema cases. What about complicated pneumonia incidence? There are 3 distinct periods. The first one is the period before the use of pneumococcal conjugate vaccine, actually before PCV7. There was a notable increase in the incidence of complicated pneumonia in late 90s and early 2000s. For necrotizing pneumonia, we can see that it was in 1994 that a case series of 4 patients was published. And although still is regarded as uncommon, the incidence of necrotizing pneumonia may be increasing in cases admitted to a tertiary pediatric hospital. It is estimated that you have necrotizing pneumonia in 0.8 to 7% of all cases of community-acquired pneumonia. And then you can have a combination with empyema in 20% of these cases of pneumonia. Regarding empyema, it was mid-90s that a short note came from Birmingham describing a clear increase of empyema cases in children with pneumonia. Around the same time, we have a paper from the States presenting increase of the incidence of empyema. That's again before the use of a PCV. And around the globe, from Taiwan, again in the same period, an increase of complicated pneumonia cases, actually related to Streptococcus pneumonia, according to the paper related to virulent isolates, and having cases of empyema, either alone or in combination with necrotizing pneumonia. The next period is when PCV7, the heptavalent pneumococcal vaccine, was introduced. And that's a nice presentation of the rate of empyema-related hospitalizations in the United States. Actually, PCV7 was introduced in 2000, and you can see through 2010 that it was a clear increase. You can see it was apparent, the increase in 2003, and a peak in the incidence noted in 2005. But another country, there are several countries showing increase around the time of the use of PCV7. That's Australia. In Australia, PCV7 was introduced in January of 2005. And you can see in children less than 1 year or between 1 to 4 years old that there was increase in the hospitalization of children for pneumonia with empyema. Well, what about the etiologic agents? Complications of pneumonia are associated mostly with Staphylococcus aureus, either MSSA or MRSA. And after mid-90s, PVL positive isolates in certain countries with increased rates of these isolates. And the other agent, of course, was Streptococcus pneumonia related to some strains that they were both virulent and in several cases also multi-resistant isolates. We can see for necrotizing pneumonia data from Boston. That's up to the beginning of 2005, with first in the rate Streptococcus pneumonia, and following that, Staphylococcus aureus. Actually, it was the time that in 2003, 2004, there was increased rate of MRSA. From Utah, that's an area that several studies on empyema have been conducted, and they have studied very carefully pneumonia with empyema. We have a publication showing that the cases of empyema or necrotizing pneumonia and cases that required chest tube placement and cases that underwent surgical procedure were caused by serotype 3 when they were compared to the other serotypes. And actually, the other serotypes were mostly serotype 1 and serotype 19A that in the middle of 2000 increased circulating in the United States. What happened afterwards? Well, it was the era of new molecular methods applied. One publication that was from Spain, they presented pneumonia with or without parapneumonic effusion. And actually, they had around 200 samples of pleural fluid. And when they used blood culture and or culture of pleural fluid, they were able to find the etiological agent in a little bit more than the 1/4, and actually mostly Streptococcus pneumonia. When they used PCR in the cases that they had negative blood culture or negative culture of pleural fluid, there was increased rate of identification of Streptococcus pneumonia. You see that 99 cases out of 118 were shown to have been caused by Streptococcus pneumonia. Actually, in this paper, they went ahead and they looked, in addition to PCR, the isolates by multi-locus sequence typing by MLST, and they looked the different strains that caused the parapneumonic effusions. So we have new molecular methods analysis of pleural fluid to play a significant role that leads to a redefinition of empyema. A positive PCR of pleural fluid is considered to be a new index for empyema, for the empyema definition. So we started with the period before PCV. We had the PCV7 period, and then the third period was with the introduction of PCV13. we saw this presentation for the United States before. When PCV13 was introduced in the States, it was a clear-cut decrease of the rate of empyema cases and went back to the rate that you can see in late 90s. Complicated pneumonia caused by Streptococcus pneumonia. You can see the reduction with the use of PCV13 in the United States. And actually, you can go around the globe and see different papers from different countries with the reduction of empyema cases after PCV13 implementation. Overall, it's between 40 to 60% reduction, although studies from Spain show reduction between 70 to 80%. In Italy, they looked at the reduction regarding the serotypes of pneumococcus. And actually, the reduction was significant for all except serotype 3. There was not some reduction, 31%, but it was not significant. Well, the data from the Netherlands, it's actually interesting to see the 3 periods that have been published. It's interesting that it was an incidence reported as 0 before the introduction of pneumococcal conjugate vaccine for pneumonia with empyema. And then there was an incidence that was increased to 0.14 with the use of PCV7, and then with the use of PCV10, an increase that went up to 0.29, but this was not statistically significant. The 95% confidence interval were quite broad. So new pathogens identified during the PCV's period, well, from PCV7 through PCV10 through PCV13 by molecular techniques. We have publication from Italy looking data from 2006 to 2018. And they looked pediatric parapneumonic effusion. We can see that around 3/4 is pathogen to be Streptococcus pneumonia, 10% Streptococcus pyogenes, and 3.7% Staphylococcus aureus. The interesting point is that there was a whole spectrum of different etiological agents that before had not been identified causing parapneumonic effusions. There is another study from Germany that I think that complements the data from Italy. It is a prospective study from 2010 to 2017 that they studied cases with parapneumonic effusion / empyema. Actually, they tried to use both the terms. And what they saw, the first was, as we expected, Streptococcus pneumonia. Second, Streptococcus pyogenes. And third, Staphylococcus aureus. What's quite notable is the incidence of several different streptococci. And we can see also something that's not a huge number, but nobody can ignore it. That's Fusobacterium that's actually identified in this study. And looking back, Fusobacterium was identified from time to time in some cases of necrotic pneumonia, but it came up again in this study that used also PCR technique. So overall, about the trends in the incidence, we have an increase noted in complicated pneumonia in mid-90s and early 2000. We have a further increase during PCV7 period, especially in the late PCV7 period. And then we have a decline after the switch of PCV7 to PCV13. About etiology, initially, pneumococcus was the most common pathogen in complicated pneumonia. We had an increase of MRSA, especially of PVL positive isolates. And during the last decade, we have a new trend. We don't see all the other serotypes. It's mostly cases of serotype 3. Some countries report a few cases of 19A, but serotype 3 is by far the most common. We have an increase of Streptococcus pyogenes. And then, and I consider that's quite significant, a variety of pathogens identified when new molecular techniques applied. I think that's the time that complicated pneumonia is better defined with PCR, with multi-locus sequencing typing, and actually with whole genome sequencing. Thank you.
Okay, thank you for your presentation, George. So now the floor is open for questions from the audience. Maybe I can start with the question to Dimitri. I think, well, it's maybe not completely your area of what you have done research on, but there are also a lot of clinical trials going on in the Periscope project, and yeah, and I think there is also trials going on looking at a combination of whole cell and acellular pertussis vaccine, and can you already share some results on those? And maybe also what do you expect for the future, that we will give a combination of whole cell and acellular pertussis vaccine? And what about side effects? What do you expect from that?
Yeah, so well, one of the unfortunate consequences of working with IMI in an IMI project is that we cannot study complete new vaccines. So one of the conditions of the IMI framework is that we had to work with vaccines that were already on the market, so that we were able to test them, because that was the idea of having a pre-competitive research proposal. So what we did indeed is, or what we're still doing indeed, is comparing the response to wholesale and acellular pertussis vaccines, doing randomized clinical trials both in Europe as well as in Africa, in the Gambia, where we're also adding like a randomization part to the to a maternal vaccination part. So we're randomizing mothers to receive either like a pertussis vaccine or a control vaccine, and then we're randomizing the children to receive either a wholesale or an acellular pertussis vaccine. So these studies are still ongoing. So it's recruitment is still ongoing. And the European study is actually starting as we speak. The recruitment has just started, but it has been quite difficult to get these studies going in Europe. And one of the key concerns, and which also makes me a little bit hesitant, is to say is that we're going to go back to a wholesale vaccine. Is that there is a lot of negativity surrounding the wholesale vaccines. I think a lot of it is perhaps not you know, like not as severe as people assumed it would be. For example, the reactogenicity of the wholesale vaccines was actually not that bad for many of the wholesale vaccines. There was variation between the wholesale vaccines, so not all the wholesale vaccines were equally good. I think like the wholesale vaccine was actually that are in use today are actually quite okay. But I don't see that we're going to go back to a wholesale vaccine, especially in a situation where every vaccine is looked at with such how do you say that, people are very hesitant is to receive vaccination, especially if there's any hint of an association with a neurological disorder or something like that. So I don't think that's a feasible way of moving forward. Now, the other thing is that, but it might be is that we will have vaccines that look like a wholesale vaccine, but in a different formulation and a different context. I think like we have to move away from the acellular pertussis vaccines, in that they are like both do not offer the right context, so they don't induce the right type of immunity. That's one thing. But the other thing is obviously they simply don't have enough antigens. For a bacterial infection that is containing thousands of antigens, so it's too easy to actually evade immunity. Now, I think like what will also be difficult is to replace the current combination vaccines, because the key issue is obviously is like once you replace one component in the hexavalent primary vaccine, you have to test like if that affects the other components as well. So in a sense, it might actually be easier to introduce a new vaccine, a standalone pertussis vaccine that you can give either probably before the other vaccine. Now that is probably going to be easier to achieve, but it's going to be a long road, I think. And so at the moment we are discussing with EMA and trying to see like whether we can how we can get these vaccines licensed, first of all, because that's a challenge on its own, is to license these vaccines. And if we want to replace them, like it's gonna take time. But I think at this moment, like there are at least some tools available that can be used to address this. Yes.
Yeah. Okay. So you don't think we will really go back to a wholesale pertussis vaccine, but we may look at new vaccines mimicking, or at least resembling more the wholesale vaccine than the acellular vaccine.
I think like
okay.
like maybe we can go back, but then we can't call it a wholesale vaccine anymore. So it's like we have to give it a new name because there are so like a lot of negative associations with this vaccine. A lot of them that were simply not true.
Yeah.
Yeah.
Okay. Okay. So I think I'm supposed to get questions from the audience through the host, but I'm not sure how I can see them. I think they should go in the chat.
Yeah, we don't have any questions yet. Hope like let's wait a couple of minutes more to see if anyone from the audience has any questions.
So
Okay.
if it's okay, maybe I can ask you a question because you presented the data on the PCV7 and PCV10. So first of all, my question is like, so you're presenting a lot of data on disease incidence on IPD. I was wondering, do you see any carriage still in of PCV7 serotypes in unvaccinated individuals? Or has it completely gone away?
Yeah, virtually. Virtually gone away. So we do regular carriage studies in the Netherlands, and also a lot of other countries do those. So regular cross-sectional studies looking at children, looking at carriage in children, and then we see none or hardly any carriage of PCV7 and PCV10 serotypes. But the overall carriage rates have not reduced that much. So it's really replaced by other serotypes, which are not all as invasive as the vaccine serotypes, luckily, because otherwise we wouldn't have seen any effect of IPD on IPD. But so there's virtually no carriage anymore of the vaccine serotypes. Yeah, that's true.
So and because I was wondering now that like the PCV vaccines have been around for quite some time now, and I'm like, one of the things that I've noticed with Pertussis is that it takes some time to observe like any of these effects of waning immunity, etc. So I was wondering, is there like, and maybe also George will know this, like, but is there any evidences that immunity to the PCV7 or to the PCV10 serotypes, like if it's waning, because we basically only give vaccines in the first few years of life. And especially in the US, like I think like there are now birth cohorts that have like are probably almost 20 years after their first use in infants.
George, go ahead.
So, well, actually, the data from the States that they come right now are data with PCV13, and I do not consider that exactly the same for the serotypes that they were included in PCV7, although we know that there are certain serotypes, but we don't know what's happening with the PCV13 formulation, because right now in the States, there is an increase in carriage, and a little also with disease of 19F. 19F is around, that you would expect not to be a problem. So, and there are some countries that they say a little for 14. So I think that we see some changes with serotypes included in PCV7. And I think that there again, especially 19F, but the problem with some countries might be waning of immunity, especially in older children that long interval since the last dose.
Yeah, and the PCV10 and the PCV13 also, like, I mean, I know that PCV13 generally induces higher antibody responses than, at least quantities, than PCV10, at least for some of the serotypes. And there are some differences between the two vaccines. So I was just wondering if that was, if that was an issue or not.
We know that
I think
we know for serotype 19F, they have changed. It's a different. It's improved to 19F in PCV13, but again, right now in the States, they see in the carriers and in disease some increase. So I don't know, something is happening, but it's a combination of vaccine plus coverage rate, because it's not in all the states the same coverage rate. If you speak for Norway, you can have 95% coverage. When you speak for some states, can be 75%. Overall, it's 84%, something like that. So it's not only vaccine, but it's the way that they are vaccinated.
Right.
okay. I think there are some questions from the audience now. So the first question is to Dimitri, I think. What is the prevalence rate of whooping cough among under 5-year-old children?
Okay, that's a tough question to answer, because I don't think anyone actually knows this. I think also the disease incidence, not the prevalence, but the incidence is already quite variable and very much dependent on differences in surveillance systems. I think the key issue is that there is not a single surveillance system in place that has exactly the same way of working between different countries. But in general, I have to say, I don't know from the top of my head what the incidence rate is in under 5-year-olds. But I think like it's I don't know. I think it's somewhere between 50 and 100 per 100,000, but I don't know. But the number of hospitalizations, for example, in the Netherlands, of young children is quite, like, it's in the order of 200 to 400 each year, which is on a birth cohort of about 200,000 children. So that's what we see, and that's going down now that we have implemented the maternal immunization program, which is excellent, excellent news.
Yeah, maybe. Yeah. As a follow-up, I think in young children, especially, the incidence is still high in really the youngest children before they are right, sufficiently immunized. But in these young children, the vaccination still works pretty good. So after vaccination in these young children, the incidence is quite low, but especially in this before its vaccination starts, and that's where the maternal vaccination comes in.
Yeah, we see the
okay, and then a second question.
Sorry, go on.
I think also for Dimitri, is it possible to remove the symptoms still remaining after antibiotic treatment by blocking Pertussis toxin entry into cells?
So I think like the question is relating to the human infection model, like where, but maybe good to mention is that the antibiotic treatment actually works very, very well. And I think I forgot to mention that, but what we see is that, like, when we treat with azithromycin, is that, like, Bordetella pertussis is virtually gone after 1 day, and after 2 days, it's everyone is culture negative. And we don't really see like when at the moment we're colonizing these the volunteers for 2 weeks, and then we're treating them. But like according to protocol, like if they would develop symptoms before that, then we would have to evaluate them. And if these symptoms then persist or actually become more severe, then they would also be treated. But that didn't happen in phase A. So we didn't see, and we didn't have to treat any of the volunteers with azithromycin prior to day 14. And the symptoms that were there were actually still quite mild. So we didn't like none of the volunteers were treated like with antibiotics before day 14, and after day 14 is they all cleared the infection and we didn't see any symptoms.
Okay, thank you.
Yeah, George. There was I saw it was a question something whether with the new pathogens that were identified, whether it is a matter of replacement or if it is just we recognize now pathogens that we were not able before to identify. So I'm not sure. We will see. I think probably we recognize better. Definitely, you see, although the majority, it's still those that you saw before, but you see some increasing, probably might be a combination, but of course, there is some change in the pathogens that you recognize in parapneumonic effusion and empyema. And what I wanted to underline is that if you stick only to empyema, I don't think you have to combine both the cases of effusion that, well, not little effusion, but if it's more than 50%, well, actually the light criteria, they say over 50% of in the X-ray with fluid in the pleural space. So I think that's my point, that I think that there are papers that underestimated the complicated cases of pneumonia.
Yes, and that could also be a reason to see this increase, right, in the pre-PCV area. Maybe, yeah, the reporting got better over time. And
no, I think that
no,
there are so many, because the data from UK, from United States, from Spain, from Taiwan, they saw, I think it was just of increasing spread of clones, of pneumococcal clones. They were more virulent and probably also more antibiotic resistant that caused this story. Because if you go in so many different countries, just by, so the increase started before PCV7. You didn't notice that in the Netherlands, but I don't know.
Yeah, but maybe it's also good to consider is that like the pneumococcal serotypes that are circulating are not just dependent on vaccination, right? There have also been other changes. For example, Haemophilus influenza vaccination also occurred in that period of time. And that has the removal of Haemophilus influenza has probably impacted also on circulation of specific pneumococcal serotypes and genotypes because of competition in the upper respiratory tract.
And also antibiotic consumption that you have to take into consideration, because if you see the Netherlands and Finland, that they don't have high antibiotic consumption, you see less. So might be also a significant factor.
Yes.
Yeah, certainly. Okay. So there is also a question from the audience about whether pneumococcal vaccination would be effective against COVID. Well, that's an interesting question, I think. I think we don't expect any effect of that unless, well, no, I don't think so. Unless maybe you can maybe prevent the bacterial superinfection if there are any with pneumococcal vaccination. But I think no indication of effectiveness of pneumococcal vaccination against COVID, I would say. George, do you have any comments on that?
Well, I think not for children, to my opinion, might be for older age groups, but not for children, because usually you have mild clinical pictures. So I don't know.
Well, you read about like another vaccine every week that is supposed to prevent COVID, and I think like I think we're like I think the most effective treatment will be the COVID vaccines, right?
Yeah. Well,
yeah.
The fear is something that it was presented that in some areas vaccination coverage is going to drop, and I think that's the problem, because might be in the Netherlands no problem, but WHO and different organizations are worrying how the coverage is going to be in countries with a lot of COVID, a lot of deaths, with poverty, with several factors.
Yeah, no, definitely. So that would be, yeah, no, I think that's really good to monitor how the coverage will be affected by the pandemic. Yeah, that certainly goes for a lot of diseases, not only pneumococcal disease. Yeah. Okay, I think there are no questions anymore in the chat, so I think we can close the session. Well, and I wanted to really thank Dimitri and George for their presentation, and thanks to all the listeners to listen to the presentations and to put in questions. So thank you.